All right. Well, welcome everyone to our On the Pulse series. I am Chris Fortman, the CEO at the Minneapolis Heart Institute Foundation, and I am so glad that you all made time to join us. Just a little background before we get started on the Minneapolis Heart Institute Foundation. We are a separate independent nonprofit organization, so separate from the Allina Health System, separate from the Minneapolis Heart Institute. This visual kind of gives you an idea that our mission is to improve cardiovascular health through innovative research and education. You can see those in the top circles, and with the result being improving clinical practice with the dissemination of those research findings. So we have been in existence for just over 41 years doing this good work. So what is this work in research and education? We have over 200 active studies touching over 2,000 patients, and half of those studies fall into industry-sponsored clinical trials, allowing medical devices into the clinic to help our patients, and the other half, those studies are physician-initiated research. So the most important pressing questions that our physicians feel need to be answered, we have the resources to support that research. Education is a critical part. We have a paid internship program with over 200 alums here at the foundation. Most of those alumni are currently practicing physicians or in medical school. And during the summer, while those students spend their time with us, they are doing real research with our physician mentors and our research staff mentors, and many end up being authors on manuscripts and presenting at national conferences. Also in education, we provide a CME and community education and publish over 200 peer-reviewed manuscripts annually. And as I mentioned earlier, the Minneapolis Heart Institute Foundation is a 501c3 independent nonprofit that relies on philanthropic investments that come from community leaders like you. So I want to take a moment to say we are grateful for all of you who make this work possible. Thank you so much. Dr. David Hurrell is a senior consulting cardiologist at the Allina Health Minneapolis Heart Institute and chair of the Education Committee at the Minneapolis Heart Institute Foundation. He earned his medical degree from the Mayo Clinic School of Medicine, completed his residency at the Beth Israel Medical Center in Boston, and participated in a fellowship at the Mayo Clinic School of Graduate Medical Education. With interests in echocardiography and nuclear cardiology, he provides both inpatient and outpatient cardiology care. Dr. Hurrell commonly treats disorders of coronary artery disease, heart rhythm disorders, heart failure, high blood pressure, hyperlipidemia, and valvular heart disease. And with that, here is Dr. Hurrell presenting on cardiovascular testing, what you need to know.
Hey, thanks for the very nice introduction, Chris. And hey, welcome to all of you. Thanks for tuning in with us today for On the Pulse. I'm David Hurrell, a consulting cardiologist with the Minneapolis Heart Institute, and I'm glad to have you all with me today. If you've joined previous On the Pulse discussions, you've probably talked about a very complex topic and its treatment and its evaluation. And today we're kind of going to bring you down to the level, broaden it out, and talk about a wide variety of cardiovascular tests and give you some introduction to what are the kind of tests that cardiologists frequently utilize and how do we utilize those tests to best evaluate a patient. I titled it Cardiovascular Testing, What You Need to Know. Today, what I'm going to do is look at two goals. First of all, traditional risk factors. These are the tests that you all should have. And then if you experience this, consider these tests. What I mean by this is evaluation of chest pain, shortness of breath, heart palpitations or heart fluttering, something that many patients commonly experience. So the tests that everyone should have. First, let's begin with blood pressure. Blood pressure is a measurement of the pressure within our arterial walls. And a normal blood pressure is actually defined as less than 120 over 80. Now, many of you may find that these numbers I'm going to present today seem pretty tight and maybe even a little bit on the low side. but they're based upon good science. And there's a reason why we've chosen these numbers. Elevated is actually 120 to 129, with a diastolic, or the bottom number, being less than 80. Again, might find that surprising. And then when we go on to hypertension, abbreviated there, HTN, stage 1 hypertension is when your systolic, or top number, is 130 to 139, and your bottom number, or diastolic number, is 80 to 89. And stage 2 hypertension is when your numbers are greater than 140 or greater than 90. And perhaps for most of you, this is where you start to think about high blood pressure or hypertension, when you get to those type of numbers. But in reality, we should start to think about our blood pressure being elevated at a much lower number than we're perhaps used to thinking about. So good advice in terms of blood pressure. Limit your salt intake to 1,500 milligrams daily if you have high blood pressure. If you're obese, lose weight, as blood pressure definitely decreases with weight loss. I am always amazed at a patient of mine who may come in who has just lost 10 pounds, and it's dramatic sometimes how much better their blood pressure is with just a 10-pound weight loss. And if you snore or stop breathing during sleep, get tested. Sleep apnea, or stopping breathing, contributes to hypertension. I would say this is one area that's really changed a great deal in the last 20 years of cardiology. We didn't used to think so much about sleep apnea. It's a big deal, not only for things like high blood pressure, but also for some of the heart rhythm issues that we deal with. And limit your alcohol intake. There's no question that excessive alcohol intake can contribute to hypertension. The next is the body mass index. Now, the body mass index is really thinking about how much do we weigh. And the BMI is calculated here as weight in pounds divided by your height in inches squared times 703. The ideal BMI is 18.5 to 24.9. Some of you may be writing this down, but remember, Dr. Google always will find it for you too. You can always look online for the calculation, but it's a good number to know and easy to calculate. So let's put it into a real life situation. So here's an individual, 5'9", and I should mention, an individual 5'9". We're not talking about gender. We're not talking about race. It's the same for everybody. So a 5'9" individual, weight of 124 pounds or less, gives you a BMI less than 18.5. In other words, you're considered underweight. However, the same individual having a weight of 125 pounds to 168 pounds gives you a normal BMI. That's the healthy weight. Some of you might think those numbers are fairly tight, but that's the reality. If you're 169 to 202 pounds, you're considered overweight and have an elevated BMI. And if you're beyond 203 pounds, your BMI is 30 or higher, and you're actually considered obese. So why do we care? Well, it turns out that the higher your BMI, the higher your cardiovascular risk. And the risk of cardiovascular disease mortality increases even dramatically when you get a BMI over 30. So in this graphic, on the x-axis, we're showing the increasing BMI from left to right. And on the y-axis, we're showing relative cardiovascular mortality. And what you can see in the overlap, men and women are essentially the same. So as our weight starts to increase, even at a BMI greater than 25, you can see how our cardiovascular risk starts to climb. And as I've already spoken, your increased risk of high blood pressure, you can also think about diabetes. So many other cardiovascular risk factors increase as our weight increases. So know your BMI. Good advice. Exercise. I talk about exercise all the time, and here's a simple formula, because it makes sense and it's been thoroughly studied. More than 150 minutes a week of moderate exercise is appropriate for everyone. Any exercise reduces your risk of premature death by 20%. Think of that. just any exercise, getting up and moving. Meet guidelines of 150 minutes per week lowers your risk by 31%. So now you're up to 150 minutes of activity a week, lowers your risk by 31%. I mean, think of any pill that could do that. Just exercise. It's free. Exceeded guidelines with 450 minutes, lowers your risk by 39%. Boost your benefit. A little vigorous exercise reduces your risk an additional 9%, and 30% vigorous exercise reduces your risk an additional 13%. I talk to my patients about what I call intervals. So an example would be you go for a walk. For 8 minutes, you walk at a comfortable pace, and for 3 minutes, walk at an uncomfortable pace. Then go back to your comfortable pace. Cycle through that 3 times. You've exercised greater than 30 minutes. That's a great little workout, and it gives you the benefits spoken here. So go outside and move. All right, fasting blood sugar, the next test everyone should have. A normal fasting blood sugar is less than 100. Pre-diabetes is when your fasting glucose is 100 to 125. 2 consecutive readings greater than 125 strongly suggest you're on your way to diabetes. Good advice. It responds to weight loss, especially waist size. So particularly for women, think of the apple shape versus the pear shape. It's the apple shape that is at higher risk than the pear shape, and that's why they talk about waist size. Maintain a normal weight and simply move. Makes good sense. Okay, next test everyone should have. Let's talk cholesterol. Cholesterol is a good thing. It builds our cells' walls and our hormones. This is an important point, though, that most of our cholesterol is actually made by the liver, determined by genetics, 85%. Diet, for most individuals, impacts about 15% of our total cholesterol. And it kind of makes sense. Because if it was all about our diet, you could imagine that a vegetarian should have a cholesterol of 0, and well, that certainly wouldn't be good. But you also see there's other individuals where their diet is obviously contributing much more than 15% to their total cholesterol. So diet is important, but diet frequently doesn't get our cholesterol lowered as much as we would hope it would. Cholesterol intake only comes from animal protein, and I think this is another very important concept to understand. So for instance, avocados may have fat, but they don't contain cholesterol. So think meat and dairy. You're thinking about where can you get cholesterol in your diet. Total cholesterol is a measurement of the milligrams of total cholesterol per deciliter of blood, including the subtypes of cholesterol. And we're going to get into those. Cholesterol is actually carried by lipoproteins. Heard of LDL, HDL, those type of components carry around cholesterol in our body. So the general goal for your total cholesterol is 200 milligrams per deciliter for total cholesterol. That's the basic goal. In Minnesota, you know, the average cholesterol, 211. I guess they say Minnesotans are always above average. Okay, let's break it down. Now let's talk about LDL cholesterol. LDL cholesterol is the bad stuff, the worst component of cholesterol. LDL cholesterol deposits in the artery walls and causes plaque formation. Healthy goal is less than 130, and we're going to get into some exceptions to that in a minute. Treatment guidelines are based on total risk and not LDL levels alone. This has kind of changed a little bit over the last 10 to 15 years. It used to be that we purely look at someone's cholesterol profile, and from that, we would determine whether or not they need treatment. It's become much more sophisticated now so that we don't just look at their cholesterol, but we also look at other cardiovascular risk factors to see whether or not they're at a high enough risk to warrant treatment of their cholesterol. Medications are focused on statin intensity. Well, I think this is worth a few words. So on the more recent guidelines, there was an emphasis placed around if you were at high risk for cardiovascular disease or had established cardiovascular disease, you should simply be placed on a high risk or a high intensity statin. For those of you that are familiar with the statins, those would be rosuvastatin or Crestor or torvastatin or Lipitor, those more high intensity statins, and kind of do it and be done. The reality is, I think that most cardiologists don't look at it in such a simplistic way. Yes, it's true that we frequently use those higher intensity statins much more commonly than the other statins, but we still pay attention to the numbers and we try to achieve an LDL cholesterol of less than 70 for those high risk patients. So good advice is really to know your risk and reduce your dietary saturated fat to less than 7% of your total calories. Okay, HDL. Now let's talk about the good stuff. It takes LDL cholesterol and brings it back to the liver for removal. So that sounds like something you want a lot of. So for men, the goal is to have an HDL cholesterol greater than 40, and for women greater than 50. And it's not uncommon sometimes to see women that'll have an LDL or an HDL of like 100, which sounds really amazing, and it is. But there's a lot of patients out there that have HDLs like 100. Here's the point I want to make about that, where some people get concerned. They'll say, but doctor, my total cholesterol is 230. And I'll respond by saying, you're right. Your total cholesterol is 230. But remember, your total cholesterol is a combination of all your cholesterol particles. And if you have a very high HDL, you're going to have a higher total cholesterol. So not all high total cholesterol is a bad thing. Know the breakdown. So good advice. 150 minutes of exercise per week increases your HDL by 5 to 30%. Another reason to get out and move. Now, I don't emphasize this with my patients, but I got to give you the truth. Moderate alcohol use, 1 ounce a day for females, 2 ounces a day for males, does increase your HDL by about 10%. So I don't advocate drinking for those that don't, but it's good to know. Quitting smoking increases your HDL by 10%, or the other way you can think about it, smoking decreases your HDL by 10%. So shouldn't smoke. Okay. And monounsaturated canola oils can actually increase your HDL. Statins have a modest effect. So when people get placed on statins, the focus is really the lowering of the LDL cholesterol, the bad cholesterol, and not so much about raising the HDL. Statins don't do a terrific job in that regard. And triglycerides, we call it the other stuff, really from dietary sources, vegetable oil, used to store calories as body fat, increased with diets high in carbohydrates or excessive alcohol. So think people have high sugars, diabetics frequently have high triglycerides, or people that abuse alcohol. High triglycerides make LDL small and more harmful. So there is an indirect way that triglycerides can increase cardiovascular disease. The real goal is to have an triglyceride level less than 150. So good advice. If greater than 500, you really need medication. And here's an example of fenofibrate, also called Tricor, that may be required. If you're 150 to 500, think about reducing your weight, reduce your dietary carbohydrates and sugars, reduce your alcohol intake. Here's an example of where I think fish oils can be helpful. So I mentioned about taking fish oil, and also check your thyroid levels, because abnormal thyroid levels can contribute to very high triglyceride levels. And of course, I have to mention smoking. It increases your risk of heart attack by 2 to 6 times. It decreases the good cholesterol, HDL, as I already mentioned. It obviously reduces the oxygen in your blood. It raises your blood pressure. It increases your heart rate. It constricts your blood vessels. It increases your clotting time. And it increases the development of plaque and plaque rupture. It makes the plaque within your heart arteries very friable and more likely to rupture and cause a heart attack even at a very young age. Smoking is the single greatest preventable cause of death in the United States today. And fortunately, we've seen a marked decrease in smoking over the last 50 years. So don't smoke. All right, so the tests everyone should have: blood pressure, weight and body mass index, fasting blood sugar, lipid profile. Then you say, okay, doc, I've had all of those tests, but can I really be sure? Well, let's look at the development of plaque. So this is an artistic depiction of how plaque forms within the heart arteries. From left to right, you see that gradual development of plaque. And shortly after the early formation of plaque, you start to see depicted in the yellow this calcified shell and calcified plaque. In other words, fairly early on in the development of plaque formation, it starts to calcify. And then it goes on to be bigger and bigger and bigger. And then there's platelet particles and all that. And eventually you can have rupture of a plaque, which leads to a heart attack depicted on the right side of the screen. But I want you to focus on the middle and this early formation of calcium with plaque. So what tests do we have that can help us? All right, by now many of you probably already heard about the coronary artery calcium score, as we call it, the heart scan. And so I want to give you a depiction of just what those pictures look like. So on the left, we see what a normal calcium scan looks like. And I'm showing you only one slice. In reality, we go through all the slices through the entire heart to look for calcium formation. So on the left-hand side, no calcium, normal appearing heart arteries. In the middle, we start to see the formation of a moderate amount of calcification. And on the right, we see severe calcification. Now, what this test tells us is the total calcified plaque burden within the heart. What this test does not tell us is whether or not you have blockage. And that's a really important concept to understand. I love this test. I use it every week in my clinical practice. I really like it. Super helpful. There's no IVs. There's no infusion of anything. Its risk is incredibly low, the equivalent of a few chest x-rays. And it tells us so much about your total plaque burden. There is a correlation between the amount of plaque you have, calcified plaque, and the potential for blockages. So a lower score being less than 400, there's some potential for blockage. There is, but it's less likely. We start to see a lot more potential for blockages over scores over 400. But I've seen individuals with scores over 2,000 that have not had significant blockages. So that's what it tells us. It's a great screening tool. It can take the concern of I have cardiovascular risk factors, but do I have heart disease to answer that question? Do I have coronary artery disease? Great test. So higher score predicts your long-term heart attack risk, can be considered for individuals with 1 to 2 risk factors and no known heart problems. So I want to emphasize this point, though, because this comes up a lot with patients. It's not necessary for very low-risk people without heart disease. So a 40-year-old walks in and has no cardiovascular risk factors. There's really no reason why they need to have a calcium scan. The opposite is also true. And this is where I think some mistakes are occasionally made by patient selection. If you already know that you have heart disease, if you know that you've had a heart attack, you've had a stent, you've had bypass surgery, you've got a blockage in your carotid arteries in your neck, there is no reason to have a coronary calcium score performed because you already know you're a high-risk individual and you need to be treated aggressively. So the results of this test are not going to help us determine what to do. And I think that's a key point as we talk about testing today. Always think in your mind, how are the results of this test going to be utilized to change my care? And if the results don't change your care, then I would suggest not doing the test. The other thing I'll say about this is I frequently get asked about repeated calcium scores. And I think that depends on what you initially find. So if you're a 50-year-old individual with a few risk factors and you do the test and your score is 0, I might say, hey, it might be reasonable to repeat it when you turn 60, 10 years later. On the other hand, let's say you have the test done and you find out that your calcium score is 359. You have coronary artery disease. There's no value in repeating that test down the road. We already know that we need to be aggressive in treating your risk factors. And I have to tell you the honest truth, almost everybody's score goes up over time. It does not diminish, and that just makes people who are doing everything right sad. I like to say, listen, if you think about it, this is kind of like an iceberg. What you see above the water is the calcified plaque, but you know that there's a whole bunch of soft plaque sitting under the water. And as we age and as we treat the plaque, more and more of it turns into hard calcified plaque, which is perhaps in some regards a good thing because it's less likely to rupture, cause heart attacks, need for stents, that type of thing. So maybe the score going up is a good thing, but I just emphasize the fact I don't retest. So I want you to keep that in mind because that's a common question. Costs $100. It's not covered by insurance. So anyone can go in, order the test on themselves. You do not need a doctor's order to do this study, but make sure you're the right person for it. Okay, now let's move on to the second half. Specialized tests for the evaluation of symptoms. We're going to run through some of those heart symptoms and how they're evaluated, but we're going to begin by just kind of talking about what are some of those symptoms and what are the tests we utilize to evaluate them. So chest pain, obviously a very common thing, the most common reason people go to the emergency room. Shortness of breath, another common symptom frequently associated with the heart. Palpitations are heart skipping around. So if you feel your heart skipping around, your heart racing, those are palpitations. We have tests to evaluate that. Perhaps it's swelling. Why are my ankles swelling? Why do I have edema? Where's that coming from? Is that related to my heart? Maybe. Or fainting. I tipped over in church. Why did that happen? Do I have a serious rhythm problem? And then there's a whole host of somewhat atypical symptoms, but that definitely could be heart disease. Sweating, back, shoulder discomfort, arm pain, abdominal pressure. Things like this can all be heart related. Don't necessarily have to be, but they could be. Okay. So what are some of those heart diseases we're thinking about? Well, of course, coronary artery disease. We have a blocked artery in the heart. Cardiomyopathy or heart muscle disease. You have a weakened heart muscle, perhaps not due to coronary artery disease, and therefore you have resultant congestive heart failure. Maybe you have a valve problem. Either your valve doesn't open all the way, the medical term we use is stenosis, or it has improper closure and it leaks, or we say regurgitation. Or perhaps an arrhythmia, an abnormal heartbeat. It goes too fast. It goes too slow. It goes irregularly. And a common irregular heart rhythm we evaluate and treat as atrial fibrillation. So what are those common cardiovascular tests? We're going to talk about the EKG. There's monitors such as the Holter monitor, or now very commonly called the Zeo patch, which kind of looks like a big Band-Aid with a knob in the middle. Stress EKG, stress imaging tests, echocardiogram or ultrasound of the heart, CT coronary angiogram, the non-invasive test, or coronary angiogram or cardiac catheterization, the invasive test. Okay, let's take each one of these one at a time. The EKG. Here's a patient receiving an EKG, super simple test. A bunch of electrodes are put on the body, and within 5 minutes, we have a recording of the heart. I like this phrase to say it's an electrical survey of heart activity because that's just what it is. It's useful for the evaluation of suspected heart attack or fast and slow rhythms. So here's what an EKG looks like. We look at the heart in 12 different electrical vectors to produce an EKG. So this is what our EKG looks like. Normally, each one of those individual spikes is called a QRS complex. Now, we take apart each one of those QRS complexes and we look at certain segments. So here identifying the left-hand side, the PR segment, the ST segment. We talk about ST elevation as depicted in the middle, or ST depression as depicted on the right. So keep that picture in your mind as we go on. Okay, an EKG demonstrating a heart attack. In this particular EKG, there's dramatic ST elevation on the EKG. This is what a heart attack looks like. It's how a doctor utilizes the EKG to tell what may be going on in a patient having chest pain. And for reference, in the upper right-hand corner is a depiction of the normal EKG. It was changed a great deal. This EKG shows not only dramatic ST elevation, but some reciprocal ST depression as well on the left-hand side of the EKG. How about heart palpitations? Someone comes in and said, "Doc, my heart's skipping around on me all the time. What in the world's going on?" Well, in this particular EKG, it's showing premature ventricular contractions, or PVCs, which are extra beats coming from the bottom of the heart or the ventricles. So another example of how we can utilize an EKG to identify what's going on. But EKGs have their limitations. So a normal EKG means you are not having abnormal heartbeats or unlikely to be having a heart attack when the test is being done. We've all taken our car to the mechanic and it never makes that funny noise. Well, this is an example in my world of cardiology. That EKG looks terrific on the day you really want to see what's going on. It does not exclude partial blockages. So if you have a blockage, your EKG can look absolutely normal. In fact, if you've not had a heart attack, your EKG can look absolutely normal, even though you may have lots of blockages. So rhythm problems, same story. It's while you're doing the EKG and it's only measuring, your heart rhythm for a few seconds, you may not be having symptoms. It may not show us what's going on. Let's go on next to echocardiograms. An echocardiogram is really an ultrasound of the heart. It's non-invasive, no needles, no drugs. It's a really convenient test to have done, and it tells us so much. If we do it on the chest wall, it's called a transthoracic echocardiogram, or just a regular echo. If you're actually put partially asleep and you swallow down a probe, we call that a transesophageal echocardiogram, or TEE. So typically we think of an echo or a TEE, and they each have their own indications. In this particular slide, the artist depicts different chambers of the heart, the other valves of the heart, and above we see an echo image that actually lays out for this in really beautiful form, the anatomy of the heart. Well, let's look at a living picture. In this example, we see the heart depicted, and we can see the valves moving. We can see the strength of the heart, the size of the heart. Is a valve sticky? Is it leaky? We can look by putting on color. There's so much information. This is a normal appearing heart. Here's an example of a transesophageal echocardiogram, or TEE, in a patient with fever and what's called endocarditis, or infection on the heart valve. Not a good thing. And there's a mass on the valve. It's very friable and mobile looking. This is an infected heart valve. We get beautiful pictures by TEE when looking for medical conditions such as this. Or how about this patient having a regular echo again, who comes in with shortness of breath and fever in the setting of a viral illness? This is a large effusion or fluid collection surrounding and actually compressing the heart. Pericardial effusion is the example here. Let's move on to stress tests now. Stress tests are used to evaluate chest pain, shortness of breath, or maybe even some of those atypical features like the patient who tells you that when they walk, they get back pain. It's a great test and that inexpensive. The bad side is it's not particularly sensitive. So it's only about 75% sensitive. In other words, it's going to miss 25% of patients. And for that reason, many times when you go to the cardiologist, we'll see that we favor our imaging stress test over a regular treadmill test. Stress imaging can be done with either echo or nuclear testing, and I'll go through each of those. But the regular stress test looks something like this. You're asked to get on a treadmill, and you're hooked up with a whole bunch of EKG leads. It's cost effective. You need to have a baseline normal EKG for us to be able to interpret any abnormalities that occur with exercise. And here I show you an example of what an abnormal stress EKG looks like. Now we're talking ST depression, depicted in the red arrow. And you have, for reference again, the normal appearing EKG in the upper right-hand corner. So here we have ST depression throughout this EKG. This is a very abnormal stress test. All right, now let's talk about some imaging. If we want to evaluate chest pain or other symptoms, imaging increases the sensitivity to about 90%. It does do that at added time and cost, but there's several options. We can do a stress EKG with echo, we can do a stress EKG with nuclear imaging, and we can do either one of those, either with exercise or for our individuals who cannot exercise, there are drug infusions we can use to stimulate the heart and help give us that answer for those individuals who are unable to exercise. So here's how a stress echo is done. In this example, the patient is hooked up with all the same EKG leads. They get a resting echo performed, looking at all the walls of the heart. Then they get up and do a regular treadmill stress test, just like a regular stress test. When they reach their maximum ability, they're then stopped, asked to flop back down on the table, hold their breath, and they take additional images. And you can imagine, I hear a few complaints about that, because imagine being at the end of your ropes and then being told to hold your breath. But that's actually what we do. What's it look like? Well, it looks like this. So on the left-hand side, what you see is depicted a few different views of the heart at rest, contracting. And this is normal contraction. This heart looks like it's doing great. And on the right-hand side, those same views, but after exercise. Again, heart is really contracting well. It's doing great. This is a normal stress echo. Now let me show you an abnormal stress echo. Now this is where it gets a little tougher. But on the left-hand side, resting images, very normal. But on the right-hand side, let's take the picture in the upper right-hand corner. The top wall of the heart is moving a little bit, but it's not really thickening. It's not really contracting. And when you look in the bottom right-hand corner, see that same thing toward the tip of the heart, where it just doesn't appear to be thickening as it should, kind of in the middle there. That's an abnormal stress echocardiogram. It would suggest to us that this patient actually does have a blockage. Okay, let's go on to nuclear testing. And what does that tell us? I show you an example of what the camera looks like. Kind of looks like a donut, again, like a lot of our imaging does. But this is a nuclear camera. And we're going to talk about how it looks at blood flow to the heart muscle rather than looking at the images that we saw with the echo. So we're now trying to look at the functional blood flow of within the heart muscle. And we're trying to determine whether or not the muscle is alive, or perhaps has suffered a heart attack, or whether or not an artery supplying living muscle, that artery may actually have a blockage. So I'm going to just show you one example of an individual who has a heart attack. Now, this is kind of complicated to look at, so I'll try and explain it the best I can. When we do assessment of nuclear imaging, we try to look at the heart in 3 different planes, and at stress and at rest. So in this particular example, the first row is after exercise, looking at the cross-section of the heart. The second row is at rest, looking at the cross-section of the heart. The third row is after exercise, looking at what we call the vertical long axis images. And of course, the rest below it. At the bottom is the horizontal long axis images at stress and at rest. What I want you to appreciate, if we just take the top 2 rows, the top of the heart seems to have much less blood flow, both at rest and following exercise, than other segments of the heart. This is an example of an individual who's had a heart attack. They must have scar tissue on the top of their heart, which inhibits the blood flow and tells us exactly what's going on in terms of that particular area of the heart. So unlike the regular stress test with the EKG, it provides so much more information about the potential blockages or damage to the heart or the function of the heart. We can tell all of those things through imaging the heart through either echo or nuclear imaging. Well, let's go beyond the stress test now to the evaluation of the coronary arteries. The CT coronary angiogram is a terrific test. It's now been in wide use for perhaps the last 20 years. It has 95% of the accuracy compared to the invasive angiogram. It's a non-invasive test. It's low risk, and that's why we really like it. Invasive angiograms, on the other hand, are the gold standard. They're nearly 100% accurate. They're invasive. They're costly. They have higher risk due to the use of catheters within your body. They're only used when very likely a blockage and need angioplasty or stent. So think about the disadvantage of a CT coronary angiogram is that you can't treat anything. In other words, it's a diagnostic test, but it's not a therapeutic test. On the other hand, an invasive angiogram is the gold standard, and it allows us to treat a blockage if we see its presence. You might be thinking, well, why would we do a stress test if we can just go on to a CT coronary angiogram or an invasive angiogram? Because a lot of times there's tremendous value in understanding the functional significance of underlying heart disease. In other words, you may have a blockage, but if you have normal blood flow to that area, there may be little reason to try and open that artery and take that added risk. So functional tests like the stress test can be very useful in determining what's the best treatment. A cardiac CT looks like this, another donut, not as deep as our MRI studies. And of course, it obviously just focuses on the heart. It gives unbelievable pictures. This is a real picture taken from a cardiac CT. Look at how it can tell us exactly about those arteries. And it's just really, really neat. But when we take apart these arteries to provide diagnosis about blockages, we go on to these next set of pictures. In this example, we've looked specifically at the left anterior descending artery on the left circumflex artery in the middle, and the right coronary artery on the right. You can see by specifically identifying each of these three main heart arteries, it allows us to get beautiful pictures of the arteries to depict a potential blockage. How about invasive angiogram or cath? Well, in these artistic depictions, on the left-hand side, we see what the heart really kind of looks like in the chest. And on the right-hand side, we see the picture we actually get when we actually put a catheter up into the heart, inject dye in each of the heart arteries. Only when you inject dye in each of the heart arteries can you actually see what's going on with the blockages. So here's what the real pictures look like. But in this particular slide, I'm going to contrast what we see on invasive angiography versus CT scan and just show you the beautiful correlation. So on the left-hand side, this is what a real angiogram looks like. And the red arrow is depicting a blockage within the left anterior descending coronary artery. On the right-hand side, we're looking at that exact same patient and the CT coronary angiogram depicting that blockage. Look pretty similar, don't they? Next, let's talk about cardiac MRI. Well, this is the big donut that most people fear, but it's a wonderful test and tells us so much more and different information than the tests I've talked about already. It has very high resolution, but it may take up to an hour. So besides the deeper donut, the longer test time, it's not always as popular with patients, but can be incredibly useful. Here's just an example of a cardiac MRI and just the beautiful pictures you get. I mean, just look at how you can tell so much about the anatomy. You can look at the heart muscle to say, well, do we see scar tissue? Do we see inflammation? We can look at the vessels to say their sizes. Has there been a break in a vessel wall? We call it dissection. It's just really, really cool stuff. So very, very useful test. Now, I want to point out one other slide here just about cardiac CT. We've kind of focused on CT being used to look at heart arteries, but it too can be very useful for other things beyond just the heart arteries. Here's a patient who has a mechanical aortic valve, and they come in complaining of shortness of breath, and the doctor notices that they have an increased heart murmur. And what this CT is depicting is this valve is not opening all the way. It opens, but it doesn't open all the way. So something must be inhibiting the appropriate function of this valve. So here's how we can use CT to look at metal. As you might know, metal can be a real problem with MRIs, but not with CT. Okay, so lots of tests. Talked about a lot of different stuff. Which test do we really choose? So let's take this one step further and talk about patients and their symptoms. So commonly utilized tests for somebody who comes in talking about skipped heartbeats, lightheadedness. Of course, we're going to get an EKG. It's usually the initial test to start with because it gives us that great electrical survey of the heart and may give us an initial hint about what's going on. Monitors. I haven't talked a lot about monitors except to say that there's Holter monitors and there's the Zeo patch. A Holter monitor is usually for 24 to 48 hours, gives us a continuous recording of the heart, or a Zeo patch, 3 days to 2 weeks. Good if the symptoms are less frequent, less than daily. And one that I didn't mention is we now have loop recorders that are actually implanted in the chest, and those can be good for 2 years for those very infrequent events. So lots of different ways to monitor the heart to identify what's actually going on. We like to get blood tests. We think about electrolytes. What's your sodium, your potassium, your magnesium, your thyroid function studies? All of those can be very important to elicit what's going on with a patient who's complaining of palpitations. General rule, though, is if the exam, echo, EKG, monitor with symptoms, if you want to do that monitor and have symptoms, and all your blood tests are normal, the palpitations are likely not harmful. I always tell patients that I feel my job is to identify the needle in the haystack, but most patients will be hay. Fortunately, it's a good thing. Good advice, reduce caffeine, alcohol, or stress, emotional stress, which often contribute to these type of symptoms. Okay, chest pain, very common complaint. Again, we start with EKG, blood tests. Blood tests you may have heard of is called the troponin to look for evidence of heart muscle damage. However, this test is only of value acutely when somebody's having chest pain, not if they come into the office and say, I had chest pain a week ago. Functional tests. We've talked about the different stress tests that can be utilized, or anatomic tests, such as a CT coronary angiogram, or even going all the way to the invasive coronary angiogram. A general rule is a combination of these tests are frequently utilized to determine if a blockage is present and significant. Good advice, don't ignore chest pain, get it checked out. I see that all the time. Some patients done the right thing, come in, get evaluated right away, or the patient who sits at home, unfortunately having a heart attack and comes in after a great deal of damage has been done. Shortness of breath, common complaint. Let's start with an echocardiogram in this situation, because think about what it tells us. We want to know about heart function. We want to know about the heart valves. The echo is just such an awesome test to give us all of that information. A chest x-ray, even a common old chest x-ray, can be very helpful as well. Maybe something's going on in the lungs. Maybe there's fluid congestion. Maybe there's pneumonia. There's just some underlying lung disease, COPD. Those things can be determined many times by a chest x-ray. Of course, we love our EKG. Maybe there's an underlying rhythm problem. Maybe the heart rate is too slow, and that's why they're having shortness of breath. Or stress tests. Maybe they aren't having chest pain with activity, but they're having shortness of breath with activity, and that shortness of breath is really due to blockages, which can be detected by stress tests. And sometimes we use pulmonary function studies. You know, you blow in the tube to really see how well do your lungs really work. And blood tests. There's a funny blood test called the BNP. That blood test is utilized to objectively tell us whether or not there appears to be fluid congestion in the lungs. So some of you may have heard of a BNP test we utilize just for that purpose. General rule, shortness of breath really has a long list of possibilities. It may take a combination of these tests to determine the cause, or even other tests I haven't talked about today because they go outside the field of cardiology. Seek advice from your primary care provider as to really where do you start your evaluation for shortness of breath, because it can go in so many different directions. So in summary, everyone should have assessment of their traditional risk factors, as I've talked about today. For those people with concerning symptoms, consider specialized testing to better define the cause and the appropriate treatment. And come see us. We'd love to take care of your heart concerns. And with that, we'll open it up to some questions today. And I want to thank everyone who provided questions to us. And unfortunately, there were so many. I had to kind of consolidate some of the questions, but I definitely want to try and answer some of those for you today. And of course, for future On the Pulse events, you can always submit your questions, and perhaps they can be answered in a future On the Pulse.
All right. Well, thank you very much, Dr. Hurrell, for your time and expertise during today's On the Pulse session. Phenomenal presentation. And hello, everyone. My name is John Rickert. I'm the virtual event lead here at the Minneapolis Heart Institute Foundation. Just will be jumping on here to help facilitate the Q&A. And as Dr. Hurrell mentioned, these questions all came through via registration. So thank you to our registrants who submitted a question. However, please feel free to add additional questions using the Q&A pod, which is located at the bottom of your Zoom screen. We may use these questions for future On the Pulse sessions. And with that, the first question is a little lengthy, so bear with me here. But the question is, my family has a long history of cardiovascular issues, including atrial fibrillation, high cholesterol, and heart disease. What tests can I be doing before I'm diagnosed with these health issues to prevent or minimize my genetic predisposition to them?
That's a great question. It does cover a lot of ground. So obviously, high cholesterol, start out with just a cholesterol profile. As we talked about today, everyone should have that test. Atrial fibrillation gives me the opportunity to bring up something I haven't talked about yet today. The world has evolved a lot to having home monitoring of so many different things. And many of us are wearing these fancy watches these days, or there's other devices that can help us detect arrhythmia. So first of all, as I said, start out with an EKG if you're concerned about atrial fibrillation, just to know, do I have it or don't I not have it? But remember, atrial fibrillation is a rhythm problem that can kind of come and go. So as a result, having your own heart monitor at home might be a way for you to monitor whether or not you have future concern. And the third is for just underlying heart disease. We talked about the heart scan today, or looking for a coronary calcium score. It's another way to detect whether or not you have underlying heart disease.
Absolutely. And thank you so much for that insight. And so you had mentioned smart devices and some gadgets. So I'm going to skip to a question that has to do with that. And the question is, if you could speak to the reliability of these new gadgets like smartwatches. This attendee specifically calls out the Cardia device to measure heart health.
Well, Cardia is a great device, and I use it a great deal. It's Cardia spelled Kardia. And it's about a 3-inch little metal device that you put your fingers on, and it's connected to your smartphone, and it can tell you whether or not you're in a heart arrhythmia. Now, it's not perfect, but it's an incredibly useful screening tool for individuals who have infrequent symptoms. The same can be said for the Apple Watch. Obviously, that's a great deal more expensive, but you have it on you all the time, where the Cardia device you may not always have in your pocket. So the Apple Watch can be very helpful in that regard too. Are they reliable? Well, again, they give us a good hint as to what's going on, but they are not always diagnostic. So as a result, we frequently have to do the monitors I spoke about today if we see evidence to suggest something like atrial fibrillation or supraventricular tachycardia. Some of these abnormal rhythms are going on.
Absolutely.
I like them.
Yeah, and I think that, as we continue on here, I'm sure that more devices will come to market. And I just wanted to give a quick shout out as if you're curious to learn more about any sort of smart devices in terms of your cardiovascular health, we did do a full On the Pulse session about that topic earlier this spring, which I can add a link to in the chat pod at the end of this session here. But thank you so much for that, Dr. Hurrell. The next audience-generated question is there, so you talked about HDL and LDL. So is there such a thing as too high of an HDL or too low of an LDL?
Yeah, it's a common question, and the answer is no. We have not identified any issues with someone having too high of an HDL, nor have we identified a problem with too low of an HDL, because sometimes that happens too for patients that are on these lipid agents and their LDL really drops to the floor, say to 30, and they think, boy, is this dangerous? There's no evidence at this point in time that it is.
Absolutely. And thank you very much for that. So the next question, I do see a lot of buzz about calcium scoring. So this attendee asks, calcium scoring, is it safe?
You know, calcium scoring is very safe. It doesn't involve an IV or any type of injection of any kind. It's the equivalent of just a few chest x-rays. So it's very, very low radiation exposure. I want people to always still keep in mind, I'm going to reemphasize the point I said earlier, because there's no IV dye, it can't tell us about blockages. It can just tell us about total plaque burden, but it is a very safe test.
Yeah, seems like a great tool for sure. So let's see here. The next audience-generated question is, can a person still have arterial plaque or carotid plaque with a coronary calcium score of 0?
No, they can. I saw a patient this week who had a calcium score of 0, had very typical type chest pain, and went on to a CT coronary angiogram, now with the dye, that showed that she had a blockage despite a calcium score of 0, and she had successful stent placement. So you really have to listen to your patients and identify that needle in the haystack that has a calcium score of 0. So yes, it can happen.
Absolutely. So the next question is the last one about coronary calcium scores. And the question is, can coronary calcium scans be used on a continuing and periodic basis effectively and also economically on patients with bypass history in order to preempt more serious issues and to monitor the need for treatment adjustment and future plaque buildup?
Well, I knew that I was going to emphasize this a little bit in my talk today, and I did, but it's worth reiterating that if you have established coronary artery disease, there is no utility in repeated calcium scans to monitor things because it doesn't change what we do. If you have heart disease that's been previously identified, such as bypass surgery, we know that we need to be really aggressive in treating it, and it doesn't provide any additional useful information.
Perfect. Thank you very much, Dr. Hurrell, for that insight. So let's switch gears here and do just a couple more. The next question is, what causes ankles to show swelling with socks on?
Okay. Great question, because frequently people see swelling on their ankles and they get concerned that does this suggest that they have underlying heart disease? And for most individuals, it may simply mean that they have what's called venous insufficiency. In other words, it's the veins in their legs that are actually leaking a little bit as they've gotten older, causing them to have slightly swollen ankles. However, if there's any other concerns about the heart, an echocardiogram can always be performed to look at the heart function, to give us an indirect assessment of the pressures in the heart, and to evaluate whether or not there's any potential that swollen ankles could be heart related.
Yeah, it makes a lot of sense. And thank you very much for that, Dr. Hurrell. So let's see here. The next question is, what causes rapid heartbeats periodically?
So there's a lot of different heart rhythms that can cause periodic racing of the heart. And that's why the monitors are so important. You know, every once in a while, someone will come in and say, well, I'm having intermittent atrial fibrillation. And, you know, you say, well, how do you know? And they say, well, it feels like atrial fibrillation. And I said, well, I think we really need to know because there's a lot of treatment implications to what arrhythmia you have, whether or not it be, as we talk about, an SVT versus atrial fibrillation versus atrial flutter. There's so many different heart rhythms out there that's why the monitors are so useful to really kind of nail it down and individualize the treatment based upon the findings.
So the next audience-generated question has to do with monitoring mitral valve prolapse. And the specific question is, what is the best test to monitor mitral valve prolapse?
Well, I thought this could be a good kind of test question at the end, because I would hope by now you'd know that the echocardiogram is a perfect test. So if you have mitral valve prolapse, an echocardiogram on a periodic basis is the best way to monitor that particular valve abnormality.
Perfect. So let's just do a couple more here and then we can wrap it up. I appreciate your time, Dr. Hurrell. So the next question is, at what point should a patient schedule an appointment with a cardiologist?
Yeah, you know, it's a great question. here's what I like to say is I think first you need to begin with your primary care doctor and talk with them about the symptoms that you're experiencing and what it might be so that they can give you some advice and direction. And they may want to start with a few simple tests like an EKG, like an echocardiogram, and based on those findings, decide that it's best to now go on to a cardiologist. So I would say that that's the best path for most people. I will admit that the calcium scans have kind of changed things a little bit because frequently if people have a calcium scan, which they've done on their own, which is fine, they'll then decide to go directly to the cardiologist if it's abnormal. So we see a lot of patients who are self-referred, but many times come through the pathway of their primary physician.
Mm-hmm. Absolutely. So what excites you most about the future of cardiovascular testing?
In many ways, it's the past. I've been in this business long enough to know that what I think is impossible, we're going to be doing next year. And with the development of cardiac CT, cardiac MR, it's shown us so much more than what I knew in my own training. And now if you look to the future of things like cardiac CT, what I want to know is not just, do you have a 50% blockage, but I want to know what's the likelihood that 50% blockage is going to go on and rupture and cause a heart attack. And that's where there's a lot of science and research that goes on in areas like that to help us know, because frequently patients will come to me and say, well, I know I have a 50% blockage. Why don't you just stent it now? And I try and talk to them about the risk of opening it at this point in time. But perhaps in the future, we'll be able to say, well, you have 3 different 50% blockages, and this one of the 3 is at risk of rupture and may be appropriate to treat now. So I think we're going to have new imaging tools as the future goes ahead, and that's exactly where I want to be. So anyway, a lot of fun happening in cardiovascular diagnostic tests.
Yeah, and it's absolutely fascinating. And with the onset of, the advancements of technology and perhaps, artificial intelligence at some point playing a role, really fascinating to see where this field will go. But
as long as it doesn't take away my job.
Well, there's that too. Yeah, definitely not yet. But I do think that was a pretty good question to wrap up on. But Dr. Hurrell, thank you so much for your time. Are there any final words that you'd like to say to our audience before we sign off?
I just want to thank everyone for tuning in today. It's terrific to have you a part of the Minneapolis Heart Institute Foundation, the education that the foundation provides. And I hope that you tune into future events as well. Have a great day.